Thank you for joining us today for our webinar on food allergy and asthma, how they impact each other. I'm Jennifer Gertz, Executive Director of Food Allergy Canada, and our guest speakers today are Dr. Douglas Mack and Dr. Mariam Hanna. Before we get started, just a few housekeeping items. This session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar, and this webinar will be recorded and shared on foodallergycanada.ca afterwards. So a little background on this session. We know from many of you in our audience that you're managing either yourself or for your child or patient more than just food allergy, and asthma is frequently cited as one of those additional conditions. With seasonal allergies underway, presenting perhaps more asthma triggers for some, we felt now would be a good time to address the topic of asthma and how it can potentially impact food allergy. From the submitted questions at registration, and thank you to everyone who did that, there are lots of questions, and we're delighted to have our experts join us to share their expertise and answer these questions. So here's the format for today's section. We have broken the content into two parts. The first part will be a discussion around food allergy and asthma, its relationship with each other, prevalence, and then essentially an asthma 101, what it is, symptoms, diagnosis, trigger, and the management. And then we're going to go into a second section on how asthma impacts food allergy, the potential severity of reactions, knowing the difference between an asthma attack and anaphylaxis, and what to do if you're unsure. And then a discussion about special considerations for those undergoing or thinking about food allergy desensitization treatments. So we'll hear from our experts in each of these content areas, and then we're going to stop and we're going to address some of the pre-submitted questions we received, and then we're going to go back to the second part. Now, if you have some questions during the session, please submit them in the chat box, and we'll do our best to try to get to as many of them as time will allow. Now it's my delight to introduce our guest speakers today. Dr. Douglas Mack is a pediatric allergy, asthma, and immunology specialist. He is an assistant clinical professor in the Department of Pediatrics at McMaster University, on the board of directors for the Canadian Society of Allergy and Clinical Immunology, and on the executive for Allergy and Immunology for the Ontario Medical Association. We are also joined by Dr. Mariam Hanna. She is also a pediatric allergy, asthma, and immunology specialist, an assistant clinical professor in the Department of Pediatrics at McMaster University, and the section chair in allergy immunology for the Ontario Medical Association. So to get our session started, we'd like to start with a couple of poll questions. So let's pop up those questions. So if we can have our audience answer this, the chance of having asthma in someone that already has a food allergy is, and your choices are 5%, 10%, 20%, or 50%. So we've got almost half the people indicating 50%. So let's go on to our second poll question. A person can be diagnosed with asthma by which age? Select one of the following. So less than 2 years old, 5 years old, 8 years old, or 12 years old. And we've got more than 50% indicating less than 2 years old. So at this point, I'd like to turn it over to Dr. Hanna to give us some insights on those poll questions and dig into section 1 of our webinar.
Thank you very much for the introduction, Jennifer, and thank you to Food Allergy Canada for allowing us to share some thoughts and some new knowledge for you guys about food allergy and asthma. We've done a really great job with the polls so far. It looks like a lot of people already have a lot of information about the relationship between food allergy and asthma, but this topic is near and dear to us in this specialty, and so we thought we would take some time to review the basics. So to start off with, absolutely right, you guys, approximately 50% of patients with food allergies also will have the diagnosis of asthma at any point in their life. Food allergies are not in and of themselves causative of asthma, so food allergy does not cause asthma, and similarly, asthma does not cause food allergies to occur. food allergies being present does not also lead to having chronic, uncontrolled asthma symptoms day in and day out. The relationship really lies in this allergic march that many of you have already heard about, with its hallmark symptoms of eczema showing up in early childhood, followed by the presence of food allergy, that red line that you see on your screen, and then with the development and diagnosis of asthma, and followed by environmental allergies like seasonal allergies. Asthma in Canada is one of the most common chronic respiratory diseases out there. It affects all ages, from very young to very old. However, younger Canadians are disproportionately affected. At present, there is no cure for asthma. It can be very well controlled to the point that patients with well-controlled asthma will have a very normal life with zero symptoms by maintaining a healthy lifestyle, learning to avoid allergen exposures and triggers of their asthma, quitting or avoiding smoking, and taking their medications properly. In this next graph, I'll show you the prevalence of diagnosed asthma in Canadians from age 1 onwards has really not changed over the years, with a high predominance of males to females in the younger age groups, and as we see them get older, more often diagnosed in females than males. We see a spike in the curve for a higher incidence of asthma diagnosis in our young children, and particularly around adolescence, but certainly throughout life, we can see the diagnosis of asthma be made. So what are the symptoms of asthma? Asthma presents with breathlessness, feeling of chest tightness or pain, persistent coughing. This is especially heard at nighttime with strong emotions like laughing really hard or crying, with exercise-induced cough. Wheezing, especially common among young children, and symptoms that are exacerbated due to a respiratory illness. Any respiratory illness tends to cause more significant cough, more persistent symptoms than in somebody else that does not have asthma, for example. So how do we come up with this diagnosis? Well, it's a combination of things. First off, personal and medical history. So what does the symptoms sound like? What other medical conditions does the patient have? Physical examination, signs of other allergic diseases, and signs of asthma on physical examination. Breathing tests. So breathing tests is where it gets tricky. In some ages, we can't perform them, but at 5 and up, we can start doing a breathing test known as spirometry, which you'll see a picture of on the right side of that screen. But there are other breathing tests that can be done, other provocative testing that can be done that helps to confirm or refute the diagnosis of asthma. And finally, response to medications. So even if we don't have a breathing test, or even if the exam is not showing symptoms of asthma at that exact moment, if we have enough suspicion off of personal and medical history, a medication trial will be used, and a response to that medication trial will help to confirm the presence or diagnosis of asthma. This is often done in very young children. So again, asthma can be diagnosed at any age. The most common thought is that we need to have spirometry to make this diagnosis. And that is certainly helpful, but not required. And what you'll see in the picture here is an older gentleman who is doing a spirometry test. And what this involves is plugging in the nose, taking a big breath in, and blowing really hard through a spirometer. And what the spirometer can show us is a flow volume loop. And I'll kind of explain it. So what you see in the blue loop in the upswing is somebody that takes in a big breath in, and then they're going to blow it out through that machine. And what they blow out hard and fast is their expiratory volume. And we care about how quickly they can blow it out and how completely they can blow it out. And what happens is that the changes that we see in an asthmatic don't impact their ability to inhale or breathe in. So you'll see in the asthmatic loop on the right side of your screen, the red inspiratory curve at the bottom is almost the exact same. But when they blow out, it's like they're blowing through a small straw, and it takes longer and it takes more effort to empty out their lungs fully. And that's what you see, that scooping in the curve is that it's harder for them to blow out really fast, and it takes longer for them to completely empty out their lungs. And it's that change that is diagnostic and characteristic of what we see happening in an asthmatic. There can be triggers for asthma that are allergic, and there can be non-allergic triggers. So again, asthma is a chronic condition, but triggers will often elicit more symptoms. The allergic triggers that we talk about here are things like pollen, pets, dander, mold, and dust mites. These are things that we can often elicit through allergy skin testing, and you or your child may have had this done at any point in their life to prove or refute allergic triggers existing and potentially exacerbating asthma. Now, there's also non-allergic triggers, and non-allergic triggers can include things like exercise, cold, dry air exposure, smoke, air pollution, strong fragrances, intense emotions, and viral illnesses or infections. There are 4 key cornerstones to the proper treatment of asthma and management, and these include control of environmental factors and comorbidities, so understanding what your allergic triggers are and your non-allergic triggers are, and modifying those triggers or environment, having proper education, asthma education formally done with a respiratory therapist, an expert in the proper administration and understanding the signs and symptoms of asthma is so essential for everyone, whether you're newly diagnosed or you've had this condition for years on end. Pharmacological treatments, which we'll discuss more, so these are the medications we use, and regular and routine assessment and monitoring to make sure that asthma is well controlled. And the goal of doing all this is to control symptoms and reduce risk of exacerbations, regardless of the person's age. So as you will recognize, the most commonly used medication to manage asthma is an inhaler. And there's actually a couple different varieties of inhalers. We'll start with the controller inhalers. These are daily medications used to control airway inflammation. They need to be taken daily to control that daily inflammation that is there. And there are some brands that some families will be more familiar with than others, but these are all considered controller inhalers. If we switch over to the far right of the screen, the opposite is also available. Rescue inhalers or reliever inhalers. These are used more on an on-demand basis. They do not affect or impact airway inflammation, but they do cause brief relaxation in the airway muscles to relieve symptoms of an asthma attack. So really, these shouldn't be used very frequently, and if they are used frequently, they in fact are a good indication that asthma is not well controlled because you're not treating the underlying swelling. And then the last category, which is that center overlap that you'll see with our Venn diagram here, is that there are combination medications that can contain both a controller and a long-acting reliever. And the idea is that they provide relief for symptoms while getting that inflammation under good control. The importance of controller medications and inhaled corticosteroids are, once again, asthma is an inflammatory disease. To treat inflammation properly, a daily medication is often required. This is the cornerstone of any asthma treatment strategy we come up with. To treat inflammation, we need an inhaled corticosteroid that's taken daily, and these are very safe in the broadest sense. However, there are some things that we can do with this very safe medication to make sure that it is delivered in the appropriate place, that we are only using the doses that we need to get that good level of control, and that we're using the safest types of medications there. So oftentimes the discussion with your family doctor, pediatrician, allergist, or respirologist are all to do with, is the technique appropriate? Is the medication going where it's supposed to be going? Are we on the right medication in the right doses? So this brings me to our next poll. A child can use a puffer without a spacer. So an aero chamber would be an example of a spacer by this age. A, 5 years of age. B, 10 years of age. C, adolescent. D, never. Why is this question up here?
Dr. Hanna, I don't know if you can see the results, but the results are up. It's 30% for 5 years old, 23% for 10 years old, 21% for adolescent, and 26% for never.
Perfect. Thank you. So one of the things that I will say is that it seems like we're all split over when is the right age, if any, that we can stop using a spacer. And the whole idea of a spacer is that it optimizes medication delivery to where it's supposed to be going. And the problem that we have without using a spacer, even in the best and most coordinated of adults out there, is that a lot of the medication dose is going to hit the roof of the mouth or the top of the tongue and not end up where it needs to end up. This can lead to us needing to use higher doses of controller medication to get the same effect in the lungs, or even potentially side effects at the back of the mouth, like a yeast infection or a fungal infection, because the medication is sitting where it is not intended to sit. So medication delivery is improved and optimized when we use a spacer, and there is no upper age limit for which we would expect everybody to stop using a spacer. We want them to continue using it all the time. So any metered dose inhaler needs a spacer for any age patient. There are some things that we do to signal for us that we have achieved optimal asthma control. And the first thing that many patients think of is, well, the breathing test. The breathing test should improve. But actually the most important things that we follow include symptoms. And these symptoms and markers of control are something that even at home, you can kind of review in your mind from 1 week to the next to say, is asthma well controlled? So those 5 questions I've put up on your screen. And I think a lot of families are surprised at how minimal symptoms we expect for there to be, or else we consider it uncontrolled. So do you have daytime symptoms? This can include cough or wheeze or shortness of breath 2 or more times a week. Does coughing, wheezing, or chest tightness occur even 1 night a week or more? Do you have to use your rescue inhaler 2 or more times a week? This isn't for pre-dosing. This is actually because you're having acute asthma symptoms. Do you have to stop exercising because of asthma? And do you have to miss school or work or social activities you would otherwise want to participate in because of asthma? If you say yes to even just one of these questions, that is a marker of poor asthma control. So really your target should be basically 0 symptoms to achieve good asthma control. And in a national survey that has been done not only once, but multiple times, most Canadians are in fact not well controlled. And this perception for patients is also mirrored even by physicians. So patient perception, 93% do not have their asthma under control if you look at these 5 questions that we just reviewed. 41% of Canadians do not exercise at all because of their asthma. And that's one of the last things that we want to avoid, because exercise is good for you. It's good for your lung health. It's good for your cardiac health and the rest of your body. So asthma should not be preventing people from exercising. A third of people miss school, work, or other social activities because of their breathing, their asthma, or 43% miss out on life activities because of poor asthma control. So that brings me to the end of the first section, and we'll pause, Jennifer, for questions now.
Perfect. Thank you, Dr. Hanna. That was very useful. And if we can have our guests turn on their webcams. Great. Okay, so from some of the pre-submitted questions and ones that we received on the chat, I'd like to start with the topic of prevention, because there were a number of questions around, is asthma something that's preventable? And some in our audience are familiar with early introduction. So, is it preventable? Could early introduction of allergenic foods actually prevent the development of asthma? And then early immunotherapy, does it have a modifying effect on the development of asthma? So I'm going to turn those bundle of questions around prevention over to the two of you to dig in on that subject.
Maybe I'll jump into that. Does that sound okay? I think it's a great question. Realistically, unfortunately, we have not found that a lot of our infant interventions have made a significant difference in the development of asthma. There are some studies that show some degree of promise, but many of them have not really played out to the effect that we are seeing significant changes. So the answer is going to have to be no. So early introduction, for example, of food, early introduction of peanuts, nuts, or we even have equivocal data on whether having a cat or a dog in the home may or may not make a difference. So I think, unfortunately, this is something that we're looking at, but it's not something that we have a hard and fast idea. Now, when we talk about immunotherapy, I think there's two kinds. One is food, and the other is environmental immunotherapy. For example, allergy shots, or we also have sublingual tablets that go under the tongue. And there is actually some data to suggest that we can prevent asthma by using sublingual tablets, for example, dust mite or grass pollen allergy. So these are potential approaches for preventing the development of asthma or other allergies. But from a food perspective, even early use of food immunotherapy does not appear to play a role in prevention of the development of asthma. So those are great questions.
Okay, thank you. So just to follow on, because there was a question also that came in around, treating the allergic triggers and how that can, like if you have asthma, what those allergic triggers are. Can immunotherapy make a dramatic difference then on your asthma situation?
And the answer is yes. I mean, I think we have abundant data suggesting that that if you use specific immunotherapy, for example, you're grass allergic and we treat for grass pollen allergy, that you can actually reduce the symptoms, and not only in the short term, but also in the long term. The caveat to that is that we have to have reasonable asthma control to consider the therapy. So, there is a bit of a caution there as well, but there's some very nice data, thankfully, that shows that you can actually modify their response, and it actually has made it into asthma treatment guidelines as well.
Okay, great. Okay, so now let's move on to some questions that were related to diagnosis. So we talked a bit about diagnosis. It was a great poll question around what age can children be diagnosed. Maybe you can go back and remind the audience what the typical age is when children are diagnosed with asthma. And if you could also address in that, what are the typical symptoms you would see in a child under the age of 2?
Sure. So I'll take over that one. So there is no lower age limit for the diagnosis of asthma. Oftentimes we find asthma diagnosed in very young children because of their association with respiratory illnesses. So kids catch a ton of colds, they eventually end up wheezing with 1 or 2 illnesses, and they come to our attention at that point. There are also younger children that develop environmental allergies, and these allergic triggers can certainly cause them to go on to develop asthma symptoms. So certainly in younger patients, we see asthma developing because of either viral triggers or environmental allergies triggering them to develop asthma. The symptoms of asthma when you're under 2 include wheezing, And sometimes wheezing is appreciated by parents, and sometimes it's appreciated even by the physician when they listen to them when they're acutely sick. Cough. The emotional coughs are the big one at this age group. So oftentimes under 2 don't run marathons. They may be busy, but they're not running that marathon. And so typically when you get them laughing really hard, they'll end it with a cough or crying really hard, and then they'll have like a big coughing fit at the end of that. Or oftentimes I'll meet parents where they'll say, you know, we can't get them too excited, or else he'll start coughing. And it's that hallmark cough that's always there, that shouldn't be there, that alerts us or flags us as to potential asthma and loss of control.
Okay, great, thank you. So a follow-on question on the diagnosis piece, because there were some questions around the genetic component. So if a mother, for example, has both asthma and food allergy, you know, how does that predict the possibility that a child might have those 2 conditions?
I mean, realistically, you want to go ahead, Delphin? Go ahead, yeah.
Having a family history of asthma is important and is a risk factor and associated with having a higher likelihood of having asthma. Having a family history of someone with eczema or food allergies or even environmental allergies doesn't necessarily increase their risk. But remember, as we saw in that allergic March graph, they do have a higher incidence of having these comorbidities. And oftentimes we, you know, interesting enough, when the child finally gets diagnosed with asthma and gets proper treatment, many parents then retrospectively say, hey, I had this for a long time when I was very young, or I have these symptoms and it's possible to get rid of that chronic cough, for example.
Okay, great. So let's go on with a related question to that, because this was, you know, you shared some fairly shocking statistics around the 93% of Canadians not having their asthma under control. Why do you think it's so high, and what needs to happen here? Because it is shocking to think that 93%, that's a big number. What's your thoughts?
I think realistically, there's a couple of reasons. I think one, people get used to these. You know, people get used to symptoms that they have, whether it's knee pain, whether it's whatever. If you have a problem and you have had it long enough, you tend to get used to it. And that's personally, that's also for kids. I have kids all the time in my office. When I ask the parent, so do they cough like this all the time? And the parent says, I don't even hear them coughing anymore. So this kind of, we call it habituation, and people become what's called poor perceivers. They don't necessarily know that they're having symptoms. They just become used to it. And I think that that's part of it. And that's why, you know, in all processes, assessment and education is so important. We like to use an asthma educator to help the families learn what is normal and what is not. And that can take a lot of reframing, very difficult sometimes for adolescents or adults who have been dealing with this for a very long time. And so ensuring that they have that educational piece is so key. I think, you know, the other is access to medications, ensuring that patients are being followed up, have proper prescriptions, and are not over-relying on their reliever. And as Dr. Hanna mentioned, this is an inflammatory condition, and this does kind of go on for many, many years, and often chronically, sometimes an entire lifetime. So having a regular treatment to us is so important. And I think a lot of families will kind of fall off that wagon. Taking something daily is tricky to do, regardless of what medication it is, and asthma is no exception.
Okay, we have some other questions, but I would like to make sure that we get through the second section of the presentation, and then with the time available, we'll come back to some of the other related questions in this section. So I think, Dr. Mack, we're going to turn this now over to you.
And a question I think that we're looking at from my perspective is, can asthma contribute to food allergy severity? As we know, it doesn't necessarily cause, it doesn't cause asthma, and asthma doesn't cause food allergy, but can it contribute to severity? And I think this has been an ongoing challenge for us, and a bit of a debate for many of us. But when we look at kind of what can make a food allergy reaction better or worse, I like this diagram because it shows a wide variety of things that can contribute. So starting at the top left there, we can see kind of what was the food that the patient was eating. How was it given? Was it something that was drunk? Was it something that was ingested, etc.? Other allergy specific factors. So for example, was it baked, was it cooked, was it roasted, etc. And exactly, you know, how did that allergen present to that patient? What were the antibody levels for the patient, etc. And what were the cellular responses? Those are things that we can't really change. On the right hand side, the top right, we see risk-taking behavior. For example, taking unnecessary risks such as eating in places where we shouldn't be eating, food that we shouldn't be eating, not knowing where the source of the food was, etc., not having epinephrine or not having access to EMS. Alcohol as well, other medications or drugs, or even in some places exercise for some patients. And then the bottom left, we can also see that intercurrent infection. So having an infection may actually change the characteristics of the reaction. Having asthma or cardiovascular disease, these are two kind of modifiable risk factors. One of them we're talking about now, and then other things that we really can't change. And you know, when we think about asthma, I think what's really important for us to consider is that when you look at the normal airway on the left, it's nice and open, it's not going to get constricted, it looks very, very clear and air can pass. But when you have an asthmatic airway kind of in the middle here, the challenge we face is that it can be quite tight. The muscles in the airways can constrict significantly, and it can be filled with inflammatory cells, mucus, other types of fluid, etc. So that when somebody is exposed to something, you probably have heard of patients who have asthma that are exposed to, for example, a cat or a dog, and all of a sudden they start to have wheezing, and if they already are impaired, that wheezing can be more significant. And the same thing applies from a food perspective. Once again, remember what Dr. Hanna showed, that in a normal lung, the ability to breathe is not impaired. It's a nice, beautiful, you can imagine taking a big deep breath and blowing it all out. But in an asthmatic, unfortunately, we see on the very right-hand side, they have an inhibition, an inability to take that deep breath or to exhale, and that can lead to significant problems with difficulty breathing, like just like she said, like blowing through a straw. And you can imagine that if you kind of visualize what's happening on the left. So when we think about that, not only, for example, cats, dogs, grass, or whatever, but if we are starting already at a deficit where the lung function is impaired and the lung is already congested, having exposure, for example, to peanut or, for example, to milk can lead to worsening symptoms. And this is one of the challenges that we have seen, in fact, reported when we looked at some of the original reports of food allergy fatalities. And what was identified in this kind of early study was that about 75% of patients who experienced fatal anaphylaxis, in fact, had asthma. Now, many of these also did not have timely access to epinephrine, but many of these were asthmatic. And so it led to the hypothesis that one of the risk factors for severe or fatal anaphylaxis was, in fact, having a history of asthma. Now, when we look at some of the more recent data, it becomes very challenging. And what we are seeing are reports of an association of observations that the severity and that fatal anaphylaxis may be associated with the presence of asthma in the patient. And part of this is because life-threatening manifestations in food anaphylaxis are typically caused by respiratory compromise. So having asthma appears to be likely to have significant risk factors. But there are some challenges here, and I want to kind of make this very, very clear, is that, as Dr. Hanna had mentioned, asthma is very common amongst patients who have food allergies. So about 50% of them, in fact, patients who have food allergy will also have asthma. And the reality is, and this is very important, very few will die. And I think that is key for us to understand, that while food allergy is common in association with asthma, the vast majority of patients with both of these will actually have very successful lives. A UK study also showed very similarly that while 78% of patients who had fatal anaphylaxis in fact had asthma, the majority had not had a previous exacerbation. So, not having that, and the challenge is it's very difficult for us to do an experiment in this scenario where we say, hey, listen, you have asthma, we're going to control your asthma and then expose you to food and kind of see how things are going, and then we're going to take away all your medications so that you're not controlled, and then we're once again going to expose you to food. That would be, as you can imagine, completely unethical. So while we do have data that shows that poor asthma control is associated with more severe allergic reactions, it's very difficult for us to do a controlled experiment to see kind of what is the degree and how best to manage this. The key, I think, from my perspective, is to treat asthma. Think about the whole patient, not just to modify the food allergy severity. While that's certainly important, but to treat asthma specifically, because asthma is a long-term chronic disease that leads to, in fact, significant lung impairment and fatality. And 80% of patients who have experienced fatal asthma specifically, if they had good asthma control, in fact, may have done better. So we think that 80% are actually preventable with good asthma control. And that's something I think we need to focus on, thinking of the whole person, not just as a food allergic individual, not just as asthmatic, but what is the whole picture here? So the question is, asthma attack versus anaphylaxis, they sound like they might be similar. What to do when we are unsure? And asthma symptoms, as Dr. Hanna had mentioned, include breathlessness, chest tightness or pain, persistent coughing, exercise symptoms, and wheezing. So for many of you, that are also some of the symptoms that you may face with anaphylaxis. Now, when we look at an asthma action plan, what do we do? How do we treat that? And that includes, obviously, just like we do with other conditions, other emergencies, remain calm, take the reliever medication like Ventolin or salbutamol as directed. We have a nice action plan. We love to use action plans as part of our education for families. Calling 911. And if the ambulance takes longer than 15 minutes to arrive, then repeating the steps. And these are going to vary based on the patient, but very similar approaches, in fact, to what we would take from anaphylaxis. Now, anaphylaxis, a significant food reaction or a reaction to medications or insect stings, etc., can include multiple body systems, including skin, gastrointestinal, cardiovascular, etc. But if you look there, respiratory, these are very, very similar symptoms: coughing, wheezing, shortness of breath, difficulty breathing, etc. And when we kind of look at anaphylaxis, I often think of it as two organ systems, not necessarily one. It can present with one, but we often think of, for example, skin and breathing, or skin and stomach symptoms, or respiratory symptoms and gastrointestinal. It's kind of a rule of thumb in general, although we have lots of different classification schemes and diagnostic schemes. This is I like the kind of rule of two in general for most of our patients. But as you can see, breathing difficulty, very similar to asthma, can be listed there. And while we do have anaphylaxis action plans as well, I think if we are considering this might be anaphylaxis, the key is to use epinephrine, whereas for asthma, we may use our reliever. If we think this is anaphylaxis in a patient who has both asthma and anaphylaxis, then using epinephrine is key. And there we have on the bottom right a number of different epinephrine auto-injectors. Here they are. Here we have EpiPen, Allergy, or Emerade, with a number of different doses there. And I'm not going to go into too much detail here. You probably are familiar. You may be familiar with these, and you may even have them at home with you now. But I want to kind of, I often get the question, and I get a lot of hesitation for families who say to me, they have asthma and I'm not sure what I'm going to do if they're having an anaphylactic episode, or are they having an asthma attack? Do I give epinephrine? Do I give Ventolin? The key actually really, historically, actually, we call epinephrine adrenaline. And if you think about it, this is a quote from 1859. An English physician, Henry Salter, reported that asthma is immediately cured in situations of either sudden alarm or violent fleeting excitements, where the patient actually has an adrenaline rush. Okay, so that led people to start thinking, hey, wait a second, what is it with this adrenaline? And if you can look at that picture up there, you can see that this is like one of the original puffers, a vaporizer where you would put adrenaline in there, and the patient would inhale adrenaline. Once again, adrenaline is epinephrine. So even in the States, you can still buy epinephrine to be used as a spacer or as a medication to treat asthma. specifically. And for years, before we had more modern relievers like Ventolin, salbutamol, formoterol, etc., we were using epinephrine to treat asthma. So while I'm not trying to tell you to treat your asthma attacks with epinephrine injections, you may get a similar response. And that's why, in general, if we are in doubt, if a patient has food allergy and we think they've been exposed and they are showing signs of an asthma attack and they may have signs of hives or abdominal discomfort or whatever, using epinephrine is never wrong. And in general, we typically try to err on that side of caution. It will work very, very similarly to Ventolin, and you won't do harm. What about Benadryl? We had to throw this in. Antihistamines, we do not recommend as a primary treatment of anaphylaxis. And certainly we do not recommend Benadryl for any patient. So epinephrine is the first line treatment for anaphylaxis. Now, there are some special considerations I want to go over. Many of you may be familiar with a couple of more modern therapeutic approaches, like, for example, food immunotherapy, food ladders, or oral food challenge. And I'm going to walk you through this. We're not endorsing any of these or trying to make any specific recommendations for you. But when we look at patients that are kind of heading down the road of outgrowing, for example, a milk allergy or an egg allergy, on the right-hand side there, you've seen something, many of you guys have seen this on the web or parents groups or whatever, where patients will start with a well-cooked cookie so that the milk has been broken down. And then they're going to move up to a muffin, and then to a pancake, the milk is less broken down, and then to cheese and yogurt, and eventually milk. And many of our infants and young children can successfully move through here. And this is, once again, something we only recommend being used under supervision. And we published an article not long ago suggesting that non-asthmatics are ideal, but that stable treated asthmatics are potentially suitable. And this is really important because what we're doing is we're basically pushing the limit of these patients' immune tolerance. And like we showed above, if the patient is not well controlled and they have that excessive inflammation in their lungs, and their lungs are ready to kind of react at a moment's notice and become all tight and wheezy, having an untreated, poorly controlled patient, unfortunately, can lead to significant negative outcomes. The second thing is an oral food challenge, and many of you have definitely heard of this. And it's a diagnostic test, specifically a test at a medical facility that says, is your child allergic? That's the goal. This is not a treatment. It is to determine, is your child allergic? And takes usually about 3 to 4 hours, and we start with very, very small amounts of food, and gradually we'll give more and more of that food, in order to elicit a potential reaction, or if successful, to prove that the patient is not allergic. The problem is that the symptoms of a reaction may include cough or wheeze. So if a patient has asthma, it can be difficult for us to determine, hey, wait a second, is that cough because of their asthma, or is it because of a reaction? And that can make it very, very difficult to know whether to kind of keep going with the oral challenge, or to stop the food challenge, or to decide, is this person allergic or are they not? So we typically recommend that all of our patients in our clinic are on puffers for about 2 weeks at least, or ideally even longer beforehand, and well under good control. The other problem is that reactions can occur and may be more severe if the patient has uncontrolled or untreated asthma. And I think that that's another very, very important thing that I tell families. Once again, if you're already starting at a deficit and you react, it is quite probable that we'll have more significant problems. Finally, oral immunotherapy for food. In our clinic, we do quite a bit of this. It is a treatment approach, and the goal is not a cure, it is to increase tolerance. The symptoms of reaction, once again, as we did with an oral food challenge, may include cough or wheeze, so it can make it difficult to know, is the patient having a reaction to the food? As you gradually increase, you can see on the bottom, we start with a tiny little bit of peanut and gradually increase all the way along to their eating whatever we decide that we're going to get. This is a picture of a child doing milk immunotherapy. And reactions can occur, they do occur during oral immunotherapy in many of our patients, but they may be more severe if the asthma is uncontrolled or untreated. So we actually, in our clinic, insist upon optimal control. And in fact, I have lots of families who come to us wanting to do immunotherapy, and I have to say, okay, let's take a big step back here, because we need to make sure that your asthma is fully controlled before we even consider moving into immunotherapy. Parents are often want to kind of talk more about the immunotherapy, but I want to take a step back and say, let's talk about the asthma. Most asthmatic patients should be on regular treatment. That's what we certainly recommend in our clinic. And every clinic will do things a little bit differently. We actually will give asthma education for all of our patients and routinely monitor their asthma and potentially even alter the doses if there is an asthma exacerbation or if asthma is not controlled, to the point where we can even consider stopping immunotherapy if their asthma is out of control. So in summary, food allergy does not cause asthma. Food allergy does not lead to chronic asthma symptoms. Asthma does not cause food allergy, and it can be diagnosed at any age. Finally, for those of you considering immunotherapy or other procedures, asthma should be controlled during OIT and during other allergy procedures. And I want to bring it now open for any other questions. Thanks very much.
Awesome. Thank you very much, Dr. Mack. So I invite you to turn your webcams on, and we'll get back to the questions. Okay, that was really interesting. Lots of information to share. Let's start with going back to the risk of severe allergic reactions with asthma. So what does the data tell us? Are you more likely to have an anaphylactic reaction if you have asthma? Like, I'm a patient who has asthma. Am I more at risk of an anaphylactic reaction than someone who's not?
In fact, that's a great question. The data does not suggest that you are, in fact, more likely to have a specific anaphylactic reaction. It suggests that the severity may be more significant, more significant, and there is some suggestion that there may be a small increase in risk for more severe or even fatal anaphylaxis. But I think it's really, really key for everyone to understand who's on this call right now that simply having food allergy in the presence of asthma is not an indicator that you or your child is going to have fatal anaphylaxis. And I think that, like, I think that when we were kind of thinking about this presentation, I wanted that to be a big takeaway. We want to make sure that we do treat the asthma, that we reduce our risk as much as possible, just like you do trying to avoid exposures, etc. But I don't want this to be perceived as a potential sentence to this is what's going to happen for you or your patient. So I think that's huge.
Okay, well, let's go to that question of fatality, because one of the things that did get submitted is, there has been some media headlines around desensitization immunotherapy in asthma and fatality. So, it's obviously a great concern to the community. So I'd really like to hear from you on what perspective you can provide on some of those headlines that some of the audience may have been exposed to.
Yeah, I mean, I think it's a really good question. And, when we're looking at these patients that are going through, whether it's desensitization or other types of procedures, whether it's oral food challenges. For example, we had a fatal food challenge reaction in the States. We have got to put it in a bit of perspective because, for example, in the 50 years of using food challenges, thankfully, we've only had 2 fatal reactions during food challenges. So we are looking at the kind of overall risk. The same thing applies for oral immunotherapy. It's tough for us to really draw firm conclusions from reports, whether we've even kind of looked into those reports, et cetera. But I think what's important to take away is that unfortunately, fatal reactions are never single factorial. What I mean by that is it's never just one thing that led to that. It's kind of like we have this in place, and then unfortunately this is in place, and this is in place, and they all tend to lead to a scenario where unfortunately a severe or fatal reaction can occur. So overall, most of these procedures are very, very safe, but we do want to take precautions and while we really do feel for the families that have had these losses, thankfully, these are not common, and we can certainly learn from them. And certainly, this is what we would recommend doing in our clinic. If asthma appears to be a risk factor amongst these types of publicized reactions, then we want to make sure that we objectively look at that and make sure that those cofactors like asthma are well controlled.
Okay, so let's go on to the differentiating between asthma and anaphylaxis. So there's a few questions, some that were pre-submitted and one that's come in around using Vanillin. Should you use Vanillin during an anaphylactic reaction?
Mariam, I'll let you handle that. Yeah.
Yeah, so it's a good question. After epinephrine has been used, because epinephrine is the life-saving medication that you can give. It may have some additional benefits for airway bronchospasm that is occurring. Then you can use your reliever medications such as Ventolin. But if you have ongoing anaphylaxis symptoms, the very next medication you should rethink about again is more epinephrine, actually, not Ventolin. So Ventolin is not harmful, but the cornerstone of anaphylaxis management should always be epinephrine. If there's airway involvement, your first medication is epinephrine. You can think about the Ventolin, but if you have ongoing concern, then again, it's epinephrine.
Okay, so now let's talk about the role of antihistamines, how they fit into asthma control and management, because this is where it sort of gets tricky around, well, am I having an asthmatic reaction or am I having a food reaction? Let's just revisit that and give some clarity to the audience on, particularly as it relates to antihistamines.
Yeah, I didn't want to spend a ton of time on antihistamines because of the fact that they really play very little role in the management of asthma or anaphylaxis, and I think for asthma specifically, I have had many families who say, well, I have cat allergy and I have a cat in the home, so to treat my asthma, I'm going to just take an antihistamine. Unfortunately, antihistamines are symptomatic control, so they kind of take away like the itch, they might take away the sneezing, the mucus production, etc., but they aren't going to reduce the inflammation in the lungs. Similarly, with an anaphylactic episode, it is symptomatic. It doesn't prevent the progression of the allergic reaction to, for example, food or medication. It may treat some of the symptoms such as hives, itchiness, maybe even isolated swelling, but it's not going to improve breathing. It's not going to improve blood pressure, etc. So it is something that we can use kind of down the road or after the fact, after you've treated with epinephrine, but it isn't something that we recommend using in place of epinephrine because it will not prevent breathing difficulties or cardiovascular compromise for sure.
Okay.
Yeah, so it's a symptomatic controller.
Okay. Perfect, thank you. So another question that came in on this topic was around, once you've had an initial anaphylactic reaction, will the severity of your reaction get worse at the next exposure?
This is actually a common question that we see even outside of asthma discussions. We always wish that we had better predictors as to anaphylaxis severity, but severity is never predicted by your prior risk as to what your likelihood of subsequent severe reactions would be. So certainly we are concerned more about patients that have had severe reactions in the past, but not having a severe reaction in the past does not preclude you from having a life-threatening reaction in the future.
Okay, okay. Now I want to go back to some of the questions that we didn't have an opportunity to get to in the first section. And one of them was around, food allergy and asthma, if it can be outgrown. Like, let's say, that allergic trigger to asthma, changes. Does that happen over time? Can children outgrow these two conditions?
Yeah, no question. I mean, I think that this is something that we can, so I'll start with food. I mean, food allergy can certainly be outgrown, for example, for foods such as milk and egg. We see a high proportion of patients who have milk and egg allergy as an infant or a young child. They will outgrow it, often by school age, actually. Other foods such as peanut and nut, sesame, may be more persistent, and some of the other ones just kind of fit somewhere in the middle, so wheat maybe somewhere in the middle, soy somewhere in the middle of those as well. So, so that can outgrow. You can also develop food allergies as you get older, and that's something that is almost a different talk as well, I think. But I think from an asthma perspective, asthma also, you can kind of see different shifts. So some people will have asthma when they're young, and these are typically not allergic patients. They may not have eczema, they may not have any other allergies, and they tend to get it for a couple of years and they tend to disappear. But patients that do tend to have other allergies, such as dust mite allergy, grass allergy, food allergy, eczema, they tend to have a more persistent profile. That doesn't mean it necessarily is going to go on indefinitely, but asthma in those patients often is chronic. It may fluctuate, it may depend on their exposure. For example, if they have smoke exposure when they're younger, at home from parents, or animal exposure, etc. But it does tend to fluctuate, and it does tend to persist to some degree. Once again, that doesn't mean everyone's going to be treated indefinitely, but it does bring up the thought that these patients need to be assessed on a regular basis and to take their symptoms seriously.
Okay, one more question, then I'm going to ask you for some takeaway messages because we're coming up close to the hour. So one of the questions that came in that was submitted was around the relationship between cow's milk protein allergy and the development of asthma, as well as just kind of formula fed and whether that increases the likelihood for the development of asthma. Is there a quick answer to that question?
Mariam,
Sure.
do you want that one?
Quick question is that we don't know of a specific relationship there. And very similar to what we had said before, is that some allergic conditions make it more likely to have a diagnosis of asthma, but not one particular or specific condition increases that risk.
Awesome.
Yep.
Okay, so I would like to turn it to one of you to leave our audience with, what are the big take-home messages from this session today?
Yeah, I mean, I think that the keys here are that, look, food allergy does not cause asthma specifically. I hear this all the time. It doesn't cause asthma. It can be something we see in association with asthma. They coexist. Asthma also does not cause food allergy. It doesn't work that way. They can coexist. Food allergy does not lead to chronic asthma symptoms. And we can diagnose this at any age. We don't need a breathing test to do it. It can be very, very helpful. But we can diagnose asthma really at any age, even in our young toddlers that are walking into our office that we clearly cannot do breathing tests on. But we can certainly still make a diagnosis of asthma based on the history. And as Dr. Hanna had mentioned, the response to medication. So if we give medication to a patient and it works, chances are it's asthma. Asthma should absolutely be controlled during OIT and other allergy procedures, such as potentially food ladders or oral challenges. And I want to just once again reiterate this important point that we want to treat the entire patient, not just because of food allergy risk mitigation, but we want to treat our patients with asthma because they have asthma. If it improves asthma outcomes with food allergy, then that's great. But we want to really focus on ensuring that the whole patient is treated, not just for one condition. And so ensuring that they have good asthma control will help them now and for the rest of their life. So I think that's, those are some of my key takeaways for sure.
Terrific. Well, thank you so much, Dr. Mack and Dr. Hanna, for taking the time out of your busy schedules to share your expertise with the audience. I would ask you to turn off your webcams at this point. And I just want to, for people who are looking for more information on asthma, we would refer you to these two organizations who have a plethora of tools and information and support. And let's see if we can't get that 93% number adjusted so that we have a lot of people managing in a controlled state. I'd also like to remind you that you were going to get a short survey through GoToWebinar immediately after this webinar, and that will be popped up on your screen. You'll receive a survey in an email within the next hour, and we'd really appreciate if you could take a moment to complete it, because it really does help us inform the information needs of the community and develop new webinar sessions. So today's webinar was supported by the Walter and Maria Schroeder Foundation, the Sean Delaney Golf Classic, EpiPen, and the Peanut Bureau of Canada, and was made possible from donations of viewers like yourself. So to help us continue this type of programming, we would be delighted if you would consider a donation. You can visit foodallergycanada.ca/donate to learn more. And we would like to thank everyone for your participation in today's webinar. You can view the recording of this webinar at foodallergycanada.ca shortly. Please also share it with others who you think may benefit from this content. This now concludes our webinar.